Okay, so we'll go ahead and get started. Thank you everybody for coming out. Got some very good presentations with some excellent speakers on common but challenging conditions in sexual medicine. So to start, we'll have Dr. Denise Sasafu Adjei, who will be discussing today low libido. Dr. Asafu Adjei did her medical school at University of Michigan. She did her residency at New York Presbyterian Columbia University Medical Center. She did her fellowship in andrology at UCLA, and she is now on faculty and is an assistant professor at Loyola University. We will then have a presentation from Dr. Darshan Patel on male anorgasmia and delayed orgasm. Dr. Patel trained at Drexel University College of Medicine in Philadelphia, did his residency at the University of Utah, where he also did his fellowship in andrology at the University of Utah. He's now an assistant professor at University of California, San Diego. And our final presentation will be with Dr. Peter Bayich. He will be discussing painful ejaculation, penile pain, and painful erection with a focus on pelvic floor dysfunction. Dr. Bayich is currently at the Cleveland Clinic. He did his medical school at the University of Toledo College of Medicine. He did his residency at Loyola University and fellowship at Rush University in andrology and genitourinary reconstructive surgery. So thank you. We'll go ahead and get started talking about low libido.
Perfect. Thank you so much for having me. Thank you, SMSNA. I think we're going to have a great program tonight. I'm going to go ahead and share my screen. All right, just want to confirm that everyone could see my screen. Got it. All right, perfect. Good evening, everyone. I am Denise Asafu Adjei. I am at Loyola University, Chicago, currently where I serve as Director of Male Reproductive Medicine, and I'm excited to speak with you today about low libido. These are my disclosures. This is just a brief outline of what I'm going to be discussing. So we are going to start off just talking about like what is libido and just kind of getting around the definition, followed by I'm actually going to do a dual focus today with talking about low libido in men and then low libido in women, and then talking a little bit about some of the commonalities between the two, followed by some conclusions. So what is libido? Libido is one's sex drive or desire for sexual activity. The National Cancer Institute also has a definition that includes the mental energy or emotion related to sex. This is influenced by an interplay of hormonal, situational, and psychological factors. There's no libido scale, and there's really no normal libido for anyone. Everyone has their own baseline, and this is important as we think about what makes libido really a clinical issue. So low libido is relative to each person and really becomes a clinical issue when it becomes bothersome to that person or if it interferes with sexual relationships. It is common for libido to fluctuate over your lifetime and with different circumstances. So I think it's also important to think about setting expectations around libido and what are considered to be normal changes over the course of your lifetime. So I'm going to start off, and most of my talk is going to be focusing on low libido in men. So there are lots of common causes of low libido in men. Most of my discussion is going to focus around hypogonadism or low testosterone, but there's a lot of other things that do contribute to low libido. It's not always just the testosterone, but it's important enough for us to address it and kind of rule that out. So low testosterone will be a big part of my talk today. Erectile dysfunction, chronic diseases such as diabetes and heart disease, which lead to situations of low testosterone. So some of these are overlapping a bit in terms of things that are causing other conditions. Medications are another big category that cause low libido in men, Antidepressants, classically SSRIs, selective serotonin reuptake inhibitors, are a big cause of changes in, libido, with patients really largely just feeling like they're just kind of like numb and just don't really feel, that desire. Several other antipsychotics, and then also 5-alpha reductase inhibitors. A lot of guys are taking, for example, finasteride, which falls in that category of medications for male pattern baldness or for enlarged prostates. And so when you think about some of these things that contribute, it's really important to really rule out and look at all the root causes of low libido. Poor sleep hygiene, such as obstructive sleep apnea, can also cause low libido in men because you're just tired. Other lifestyle contributors like certain illicit drugs, smoking, alcohol, some of these have varying effects on people. You'll have patients that talk about alcohol really actually makes them have a really high libido, and some others it really depresses it. So important to think about, the effects that some of these substances may also have on sex drive. And then finally, psychological factors. Psychological factors play a huge part in your sex drive as well. If you're stressed out, if you're anxious, those are really not great settings for you to be in the mood for the most part. Also changes in relationship dynamics, which can occur in, commonly occur in lots of couples over the course of, your lifetime, different family changes, etc. And then finally, a history of physical or sexual abuse, which can really just impact body image and just, again, the desire to want to engage in sex. So I want to just talk briefly about some epidemiology around just low libido and hypogonadism. I just highlighted a study here by Arrojo et al. This was a multi-ethnic population-based observational study of almost 1,500 men in the United States, between ages 30 to 79, with about 24% of the subjects having serum testosterone levels under 300. And the prevalence of symptomatic androgen deficiency, or low T, was about 5.6%. And these numbers rose markedly to men that were above age 70. So just giving you a landscape of how common, we see low testosterone in the US population. This is a nice depiction of just the testosterone and the hypothalamic pituitary gonadal axis. It's really important to understand how testosterone is made and its interplay with other hormones to really figure out why we care about testosterone. Women have minor levels of testosterone as well, and actually also does play a role when it comes to libido in women. But testosterone is made via this axis, and testosterone has several physiological contributions besides sexual function. It influences things in bones, skin, brain function, and about 90% of testosterone is made by the Leydig cells in the testicles. Another 10% of testosterone is made at the adrenals, that you can also see there. And then you can further classify low testosterone or hypogonadism as primary or secondary, depending on where the issue is stemming from. But really important to think about this feedback pathway, especially when we think about addressing testosterone, if that is the underlying cause of low libido. This is a nice table from the AUA core curriculum, actually, that just talks about signs and symptoms of testosterone deficiency. So a lot of times, we'll have men come in the office. A big thing that will drive them is low sex drive, also reduced energy, changes in mood, inability to build, lean muscle mass, kind of depressive symptoms. So this is just a good way to kind of think about, the symptoms that men may be coming in with, so that at least if it wasn't on the top of your mind, you constantly really want to be thinking about, did I check this guy's testosterone? So that's really what this table shows, a nice list of those signs and symptoms. You also want to think about high-risk populations for hypogonadism. I have listed this here also, so that even if men may be, coming in discussing other things, these are, populations you want to have in the back of your mind that classically do have issues with normal testosterone levels. Our HIV/AIDS patients, those with unexplained anemia, bone density loss, diabetes, chemotherapy, testicular radiation, chronic narcotics, male infertility, pituitary dysfunction, and chronic steroids. And I won't belabor this too much, but something that a lot of people who, if you're taking care of any patients that have, low testosterone, they may come in as like, what about my free T or my bioavailable T? really, according to even our AUA guidelines, we largely do rely on the total testosterone. Our endocrine colleagues do have more provisions to be checking the free testosterone, but most of your testosterone are bound to carriers, specifically the serum hormone binding globulin, and the remainder is bound to other proteins like albumin. So in the free T that's unbound, this is bioavailable, pretty accurate indicator of testosterone status due to the lack of that SHBG interaction, but it's longer to process, it's more expensive. And also those SHBG levels can be variable. They're decreased in obese patients, diabetic patients, and those with chronic steroid use. And they're actually increased in older patients, cirrhotics, hyperthyroid patients, and HIV patients. This is actually a nice diagnostic algorithm that can be found at the American Urological Association's guidelines for testosterone deficiency. So also a good way to think about how you want to work up patients that may potentially be suffering from low testosterone. Some contraindications to testosterone replacement therapy include men who are actively trying to conceive, and I'll talk a little bit about some options for those guys. Patients that have active breast cancer or maybe even a recent history of breast cancer, prostate cancer known or suspected, polycythemia, a cardiovascular event within the last 6 months, and then relative contraindications include uncontrolled obstructive sleep apnea, uncontrolled congestive heart failure, and high baseline hematocrit. There are several alternative therapies for testosterone replacement in men who are desiring fertility, and I listed some of the most commonly used drugs here: Clomid, clomiphene citrate, tamoxifen, and anastrozole, HCG, and Menopur. The kind of mechanisms are a little bit out of scope for this talk, but just to give you a sense that there's several options. If a guy who is still desiring fertility is suffering from low testosterone that's vastly affecting their libido, a guy who's, a man who is trying to start a family does need to have a reasonable sex drive in order to just get the process going. So it is really important, especially in men who have low T. It's really important that we, supplement and kind of treat them accordingly. There's some other solutions for low libido in men. I mentioned before erectile dysfunction. It's interesting because it's important to remember that erectile dysfunction and low libido are distinct entities. And although there is a lot of overlap between these two, they're not the same. Erectile dysfunction, if a man does have erectile dysfunction, it may make him, have less of a desire to engage in sex. So it really is almost like this vicious cycle of my erections aren't adequate, now I don't want to have sex. And so there's a lot of overlap between the two, but just important to think about the fact that they are distinct entities. But correcting erectile dysfunction can help to rebuild confidence in men and secondarily enhance the libido. So I often do this, and I encourage other people to just ask about these as separate entities so that you can see if someone is suffering from erectile dysfunction, that may be the true underlying cause versus just, straight low testosterone or another organic cause. And then in terms of kind of male specific medication, just because of course women also take antidepressants and those have the same effects in women. I mentioned before 5-alpha reductase inhibitors, which are commonly used for male pattern baldness and enlarged prostates. For men that really suffer from low libido, you may want to just consider alternative treatment modalities, if this is a big issue in that. So now shifting gears to briefly talk about low libido in women. So, fortunately or unfortunately, libido is often more talked about in our male counterparts, but it also is a really big issue in women. I've listed here really common causes of low libido in women: low estrogen levels, especially women who are going through menopause. This can drastically affect libido levels. So really important to think about. Hypoactive sexual desire disorder, or HSDD. This is also a clinical issue that a lot of women suffer from. That also causes low libido. Postpartum periods are also associated with, big shifts in hormonal levels, which can also impact the desire for sex. Dyspareunia, or painful intercourse, which can either be from structural causes or from secondary causes like genital urinary syndrome of menopause, just because of the changes in hormones that can cause some increased vaginal and vulvar dryness. You can also have low libido secondary to sequelae of genital surgeries. If a woman has had a surgery for other reasons, body image, issues may impact also the desire to engage in sex. And medications is a common area between men and women with the antidepressants. So again, the SSRIs, antipsychotics can really blunt sex drive. Similarly, lifestyle issues and some of the psychological issues I mentioned before with stress, anxiety, and history of physical or sexual abuse. I've listed here some solutions for low libido in women and, just some things we want to think about. There are a lot of great women within, urology who, really do, address this and primarily, but it's just something that we do have to pay more attention to and be mindful of. So some solutions for low libido in women include various formulations for estrogen. I listed here, there's pills, patches, rings, lots of options. For HSDD specifically, there are two big clinical solutions. So one, Addyi, which is an FDA-approved daily pill for HSDD, specifically in premenopausal women. So that's an important population to think about. And then secondly, Vyleesi is also another FDA-approved as needed subcutaneous injection for premenopausal women with HSDD. Finally, or next, I should say, there's also off-label use of testosterone for low libido in women. I mentioned before that women also have levels of, testosterone in them, and it also does play a role in libido. So there is off-label use of testosterone. I think, certainly in the hands of someone who is comfortable in managing that, but that is also, pretty commonly used. And then lastly, thinking about dyspareunia and genitourinary syndrome of menopause, this can cause vaginal and vulvar atrophy. And so some solutions actually include direct medications that can help to kind of replenish the vaginal and vulvar lining. So some options include Intrarosa, which is a vaginal plant-derived DHEA insert for postmenopausal women, and then Osphena, which is a daily pill that alters vaginal cells and pH levels. Now, some solutions that are overlapping for men and women in terms of medications, you may want to consider alternative medications for antidepressants. Propion or Wellbutrin is an antidepressant that is associated with a better libido profile. So this is something that I encourage, patients to talk with their primary care doctors or their psychiatrists about alternatives, especially if the libido is really an issue. Chronic conditions, I mentioned before, diabetes, hypertension, and other things, compliance with treatment also just helps to, not exacerbate issues around low testosterone. Obstructive sleep apnea and fatigue, there's sleep therapy, there's workup so that, if a patient is suffering from this, they can have a CPAP, lifestyle changes, exercise, cessation of smoking, alcohol, and cessation of any illicit drugs. All things that just, again, may alter your sex drive. And then finally, psychological, and these are options that I still think are vastly underutilized, but good sex therapists, a psychiatrist, or even couples therapy. Now in the post-COVID world or current COVID world, a lot of therapists are available online, even if they're not in your vicinity. So something I really encourage both providers and patients to think about and this would be a great additive, to any medical therapy you may be getting from a urologist or another physician. So in conclusion, libido is a common issue in men and women occurring across the age spectrum and in different circumstances with variable individual baselines. Testosterone is an important factor in libido for men, but it is not always the culprit. Estrogen is an important factor for libido in women, and testosterone also is a key player for libido in women. A full diagnostic workup of low libido is important to elucidate correctable and underlying causes. And there are several treatment interventions, both pharmacologic and non-pharmacologic, that can help to improve libido. So thank you so much for your time. And I know we're going to be taking questions at the end, so I'm going to pass it off to my colleague, Dr. Patel, for the next portion of our talk. Thank you.
Wonderful. Well, I'm going to go ahead and share my screen. Well, thank you, Dr. Gross, for the invitation, and SMSNA for kind of putting everything on. Everyone can see my slides okay? Awesome. Today I'll be talking about orgasmic dysfunction and anorgasmia, specifically in men. These are my disclosures, none of which are relevant to what I'll be talking about today. I thought we'd kind of keep it simple, just start out with a case. This is something we'll kind of come back to in a few minutes, but there's a 52-year-old guy. He's coming in with difficulty achieving an orgasm, a very common complaint that you may get, certainly if you're seeing men with sexual dysfunction. Going on for 5 years, not situational, both issue when he's with his partner as well as with self-stimulation. He's got pretty good erections and reports that usually takes about 30, 45 minutes before he can achieve orgasm, but he's not always successful, has considerable anxiety, and feels that sometimes it's uncomfortable for his partner, especially if he's kind of going, that 45 minutes. And then kind of other medical history, surgical history, that's pretty much nothing. And then a couple of medications that he's on as well. So I just want to kind of get everyone thinking about this, and we'll kind of come back to this a little bit later and kind of get everyone, at least the panelists, input a little bit about this case as well. But patients that are presenting with kind of primary complaints regarding orgasmic dysfunction, they can sometimes be, some of the most challenging patients that we care for, primarily because, their expectations and understanding, what the main issues are. I think a key concept here is that, although erectile dysfunction, sexual desire certainly are much more common presenting symptoms, I think it's also really important to prioritize some of the less common, presenting symptoms, likely are underreported in terms of kind of sexual health concerns, things like ejaculatory dysfunction or orgasmic dysfunction. In terms of kind of the definition of kind of delayed orgasm, there's a lot of various interchangeable terms that are utilized: anorgasmia, delayed ejaculation, delayed orgasm. All these definitions are based on various definitions that are created by professional organizations, and for the most part, a lot of these definitions are for research-related purposes. I think one of the key things here is all these definitions are really derived for heterosexual couples engaging in penile-vaginal intercourse, so it doesn't necessarily apply to all patients that we may see. And clinically, I think the definition from the International Consultation on Sexual Medicine really is kind of the most relevant, and that's kind of highlighted in this blue box here. And that's kind of the definition of recurrent difficulty, delay, or absence of orgasm after sufficient sexual stimulation that causes the patient or their partner distress. I can't really, emphasize this enough, but a detailed history and a sexual history really is crucial when, seeing these patients and working them up. So really put in the time to get a good history. You really want to understand everything about the patient's difficulty with orgasm, whether it's situational or and whether or not it's acquired versus kind of something they've been dealing with their whole life. When exactly it started, various alleviating, exacerbating factors, estimation of intervaginal ejaculatory latency time if they are able to achieve orgasm, their erectile function and how rigid they're able to kind of get their erection, physical stamina, especially for some of the older patients in terms of engaging in sexual intercourse, and then also kind of the patient and their partner's discomfort that they may experience as a result of delayed orgasm. It's also kind of important to understand the relationship with the partner, because that certainly factors in as well. Kind of ask questions in terms of, do they have a stable sexual partner? What's kind of the quality and the duration of their relationship, and what really are, the partner's feelings about this issue as well, because it certainly can play a big role. And then lastly, kind of asking about other comorbid medical conditions, if they're on any other medications that for other reasons, any physical trauma that they've sustained to the genitourinary area, pelvic surgery, specifically prostatectomy, which is a kind of a special population that we see with orgasmic dysfunction. In terms of kind of other testing, I think at the minimum, usually I would recommend doing a testosterone evaluation, primarily to kind of establish a baseline. And this also would be for screening purposes if they're coming in with any other sexual complaints, low libido, erectile dysfunction, according to the guidelines. Other adjunct labs, hemoglobin A1C, TSH, prolactin, usually I'll do it on a case-by-case basis, or if there's something in their history that really would cue you into, one of these things kind of being a cause. These other three things that I've kind of listed here, I mean, for the most part, don't really do them very commonly. primarily for research-related purposes. Biothesiometry, really looks at kind of the sensory threshold in terms of vibratory tactile simulation. The pudendal SSEP, it's looking at kind of the afferent nerve activity from the dorsal nerve of the penis going towards the brain. Then functional MRI has been used in a couple of studies. It's basically trying to look at areas of the brain that have increased activity in patients that have delayed orgasm versus, what is presumed to be men that have normal orgasmic function. Causes of delayed orgasm, generally it can be grouped into these broad categories. The most common things that we see: medications, antidepressants, antipsychotics, and then opioids, especially given kind of the big opioid epidemic. A lot of patients are on chronic opioids and certainly can be a cause of delayed orgasm. And then lastly, in terms of kind of endocrine causes, testosterone deficiency is kind of a big player there. Moving into kind of treatment, I think it's important to really address the underlying cause if there's any there. Number one, trying to remove any offending agents, specifically medications. Doing a good medication reconciliation is certainly important. And patients that are on certain antidepressants or antipsychotics, if possible, try to work with the prescribing provider, either stop that medicine, transition them to something else, put them, if they can do like a weekend drug holiday, anything that potentially could help with this kind of side effect that's known with a lot of antidepressant medications. Sex therapy, I think this is kind of a good component to kind of the overall treatment for men and couples that are coming in for delayed orgasm. And they, can work on, masturbation retraining, looking at different, arousal methods, exploring fantasies, role play, all that kind of stuff. And kind of dealing with a lot of the anxiety that may also kind of be involved here as well. Sexual enhancement devices, so basically just penile vibratory stimulation. There's no real good evidence out there, primarily because it's hard to study, and we're probably never going to get a good study that looks at this as kind of a primary outcome. Generally, it's low risk, low burden for the patient, and generally not very costly. So if I think it's going to provide indirect improvement in their sexual satisfaction, certainly I recommend it to patients. Another key concept is, if they have other issues that affect their sexual health, you want to kind of address it. So in guys that have testosterone deficiency, after getting kind of those screening labs, consider a trial of hormone modulation or exogenous testosterone therapy, depending on their goals. Guys with ED, same thing. You want to kind of optimize that. So if they've never been on oral therapies, that's another kind of consideration there. Pharmacotherapy is kind of an area of significant interest, at least for a lot of providers that see patients with delayed orgasm. Currently there is no FDA-approved drug therapy for male anorgasmia or delayed orgasm. A lot of medications have been used off-label and used in various research studies. There's a table that kind of shows, probably the more common ones. The one that I have the most experience with is cabergoline, which is a dopamine agonist. The main reasons that I like it, and primarily based off kind of the studies that Dr. Lipschultz has done, it's easy to administer in terms of kind of dosing. It has relatively few side effects. And generally, it works about the same for various etiologies of delayed orgasm. Whether or not it's related to pelvic surgery, idiopathic, what have you. Generally, had a pretty good experience with the medication. And then cost-wise, getting it generic is not too costly or a huge burden for patients. So, coming back to, our case, like I mentioned, certainly getting a good history is very important, even beyond kind of what's kind of listed here. In terms of kind of additional workup, I did end up getting, hormone labs in this patient. And beyond that, just talked about kind of empiric management. As listed here, one of his medications is an SSRI, fluoxetine. And I think that's really kind of the first step in management, kind of having an informed discussion with the patient, kind of working with the prescribing provider in terms of either stopping the fluoxetine, changing them to something else. This medication has kind of the longest half-life, so it's hard to do like a weekend drug holiday, but other SSRIs or other antidepressants, which don't have significant sexual side effects, could also be utilized. In guys that have low testosterone, and for example, we'll say this guy, does, it's pretty straightforward that typically that's a good go-to. I'll kind of open it up to the other panelists, but, what do you guys typically do about guys that have kind of low normal testosterone? Do you consider therapy, specifically if they're kind of coming in with, complaints regarding delayed orgasm?
Yeah, I'll treat them.
Yeah, I
And
treat them.
Yeah,
if they don't have any benefit, then we'll stop treatment.
exactly. And that's kind of my, way of working these patients up. Usually I'll talk to them about, empiric trial. We'll try it for a couple of months and kind of see, what kind of improvement that we'll get. Pharmacotherapy, like I mentioned before, the question of on demand versus, kind of scheduled medications, cabergoline, twice weekly dosing versus other medications that other providers may use. Does anybody else have kind of a go-to pharmacotherapy in terms of kind of, for these patients?
Metformin for me.
I actually use Adderall.
No. What's been kind of your experience with the Adderall?
Yeah.
We published a series in fellowship. It was about, the same as pretty much every other drug that's been published on, about a 30% success rate. Guys who have delayed orgasm tend to respond better than those who have anorgasmia.
Yeah.
There's definitely, I think there are probably some different phenotypes of these patients, and maybe some of the more inattentive or easily distractible guys may do better with focus enhancing medication like Adderall or Wellbutrin.
Yeah, great point. I think at fellowship, I actually had a patient who put an Adderall after, I think, that exact paper, and he was refractory with everything else. So.
Yeah, no, that's perfect. The key thing is that all the therapies that are kind of available or have been utilized for this purpose, generally the success rate is generally poor. So I think kind of addressing all the other comorbid things and any other reversible causes is really key. And then kind of having a good discussion with the patient in terms of, these are kind of things that we have available, but, generally, some patients do find it's helpful, but a majority, don't have a big difference. I think for the most part, that's kind of everything I have. So I think kind of the main take home points here, history, like I mentioned, taking a good history is really going to pay off when working these patients up. At the minimum, I recommend doing a hormone evaluation. Other things that have been utilized for working these patients up can be considered, but generally either for refractory patients or for research-related reasons. Identifying any reversible causes, the big thing being medications that may be contributing to delayed orgasm, and kind of working with the prescribing provider in terms of getting them on something different like Wellbutrin or lower dose or like a weekend drug holiday. And then lastly, consideration for sex therapy, which I think can be very helpful for patients and couples, especially if they have a lot of anxiety about this condition, and consideration for pharmacotherapy as well. All right, thank you. I guess we'll kind of pass it on to Dr. Bayich in terms of the next presentation here.
All right, can you guys hear me okay? All right, so for those of you who don't know me, my name is Peter Bayich. I'm a urologist at Cleveland Clinic. And today I'm going to be talking about a couple different conditions that are both painful for the patient and for the, oftentimes for the treating provider, painful ejaculation, penile pain, and painful erection. So the title of my talk is Thinking Outside the Prostate, the Key to the Painful Penis is in the Pelvic Floor. I have no financial disclosures relevant to this talk. So during this talk, I'm going to talk about some etiologies of this condition. I'm going to describe the relationship between the pelvic floor and genital pain, and I'm going to propose a new framework for evaluation and management of these patients. The first disclaimer that I have is, truthfully, I am not a pelvic floor expert. As any of us who went through urology training, I would say that in general, we do not have a robust education in the functional aspects of the male pelvic floor, and that I will admit that these patients are challenging, and as I alluded to, they can cause pain to many urologists, but really they don't have to. This is something that I kind of I guess figured out based on a lot of the great things I learned on my FPMRS rotations and what we were learning about women, and I think that a lot of this stuff can be applied to men. So if I can figure this out, you can too. So these are the three painful symptoms that I'm going to be focusing on today. However, there are a number of others that are, I think, pertinent to this topic, including suprapubic pain, scrotal pain, testicular, perineal, urethral, and groin pain, all things that many urologic providers and other providers see regularly. So, what we learned in training is that these are some of the things that you should be considering when you see these patients, all the different kinds of prostatitis, urethritis, whatever that means, acute phase Peyronie's disease, maybe they have a stricture and it's related to voiding, who knows, right? There's a lot of different things you should keep on your differential, and this is just a partial list. We learned about these things like the 4-glass test with the prostate massage and, trying to identify if there's bacteria involved, and we've kind of simplified that to the 2-glass test. To make it more practical for use in clinic. And then we have our NIH classification of the different categories of prostatitis, some of which have nothing to do with the prostatitis or nothing to do with the prostate. And out of these, the one I'm going to be focusing on today is category 3B, or non-inflammatory chronic pelvic pain syndrome, also known as pelvic floor muscle dysfunction. So what I'm going to propose is that we not immediately think of doing a 2-glass test on these patients, but that we kind of reframe our mindset and maybe consider the pelvic floor as the most likely etiology of these patients. We're going to talk about the evaluation and management of pelvic floor dysfunction. So what is the pelvic floor? Well, we've got all these muscles that are kind of attached to the inside of the pelvis. I always explain to the patients that it's kind of like a basket of muscles lining the inside of the pelvis that supports the weight of your body all day. These muscles are attachments of the trunk and leg muscles. They really act as core stabilizers, and they support the abdominal and pelvic viscera. They're constantly working. They're supporting, the pelvic contents. They're maintaining continence. It's important that they, relax when they're supposed to relax and contract when they're supposed to contract. So they have to relax to allow voiding and stool elimination. Some of these pelvic floor muscles contract during erection to help facilitate, erectile rigidity. They contract during ejaculation to expel the semen, and they can, as in a lot of our patients, be affected by psychological stress. So there's this whole subgroup of patients that really seem to carry their tension in their pelvic floor. We've got different layers of pelvic floor muscles. Referring back to anatomy, you think about kind of the superficial layer of the pelvic floor, the bulbospongiosus muscle, which is integral for ejaculation, the ischiocavernosus more for erection, and then the deeper muscles as far as the ones that we think of in day-to-day function, the external urethral sphincter for urination, levator ani, or the part of that being the external anal sphincter, which is important for defecation. So if you imagine I always refer to it as the Charlie horse in one of these muscles that a patient may not know that they have. If you engage that muscle, it may cause pain. So we'll get to that in a little bit. So as far as anatomy goes, we refer to levator ani. It's really a group of several different muscles: pubococcygeus, iliococcygeus, puborectalis. These muscles attach on the inside of the pelvis to the superior pubic ramus, ischial spine, obturator fascia, and coccyx. And one of the really, I think, important points that I want to hammer into you guys today is when we think about the pelvic floor, don't just think about those muscles. Okay, I want you to think about what are the problems that a patient may have above and below this that may be causing some negative effect to the pelvic floor. So we want to start thinking like our colleagues in physical medicine and rehabilitation, and think about this concept called the kinetic chain. So if you imagine, somebody who does not have any musculoskeletal issues in any of their joints here on the right, all of their, their whole body is well balanced, operating like a well-oiled machine. If, one layer of that patient, whether it's their hip or their knee or something gets knocked out of whack, it's going to have effects on different levels. Okay, so a knee issue may have, cause a pelvic floor problem. A back issue may cause a pelvic floor problem. So how do we evaluate these patients? Well, many of them may come in with a pain symptom. They may also have some voiding symptoms, some bowel symptoms, some sexual symptoms. And these things all may be related. So we want to know the nature and onset of the symptoms. If they have pain, we want to identify the severity of that pain. Where does it happen? What are the circumstances in which it happens? Is there any sort of injury, and how did it happen? We want to really make sure we ask about those other organ systems that may be involved. So think about bowel, think about bladder. You know, so you ask a patient if they're constipated, they're going to say no. But if you ask a little bit more detailed questions like, do you have a nice soft bowel movement every day without having to push or strain? You'd be surprised at how many patients say, oh, I actually have a bowel movement every 3 to 4 days. You also want to know about sexual symptoms, any other neurologic symptoms. Sciatica is a big one that we hear all the time in these patients. So although they may not have a known history of lower back issues, you want to know if they have shooting pains that run down the back of their leg or any other neurologic deficits. Do they have any prior injuries or surgeries, any sexual trauma, which is another really important thing that can be related here. Musculoskeletal exam, most urologists are not doing a spine and extremity exam, but these are all things that you may want to consider if you think, hey, maybe this person has some lower back thing, maybe push on their, lower back. But when we think about the GU exam in the pelvic floor, you want to look for any scars. You want to do a basic sensory assessment. Do they have any major sensory deficits? The bulbar cavernosus reflex is actually a super useful thing that I do not use nearly as much as I should. I get a lot of patients that come in convinced that they have some sort of pudendal nerve problem. If the way the bulbar cavernosus reflex works is you basically pinch the glands and you're looking for a reflexive contraction of the anal sphincter. If they have normal sensation and activation of the pelvic floor with that maneuver, their pudendal nerve is fine. So as far as the pelvic floor exam, you want to think about those different layers of muscles. So we've got the superficial layer, which is the transverse perineal, bulbospongiosus, and ischiocavernosus muscles. I mean, unless a patient is super thin, you're not going to be able to feel these things unless they're tender to palpation, unless they have some sort of really tight band, which, I've seen some patients who have painful ejaculation, who have a super tender bulbospongiosus muscle on palpation. So make sure you're considering these things and actually trying to identify them on the exam, and you'll be surprised at what you find. This is another really important thing I want to emphasize, that on these patients, we're not just doing a prostate exam. If you're a urologist, you're very experienced in doing a rectal exam to check the prostate, but you may not necessarily be comfortable checking the pelvic floor muscles. So this is what we're going to do for this is basically a 360-degree rectal exam. The way I do this is I first start by putting my finger right on the anus, and I ask them to bear down like they're having a bowel movement, and I assess whether the sphincter reflexively relaxes like it's supposed to. Some patients actually have a paradoxical contraction of the anal sphincter with Valsalva, which is not what's supposed to happen and actually can be reflective of a pelvic floor issue. Once I insert the finger, then I ask them to actually squeeze around my finger and assess the strength of their pelvic floor muscles. Many of these patients give a very weak squeeze. And then once we do that, then we go all the way around looking for any tension in the muscles, comparing one side to the other, trying to identify any trigger points, which are basically painful areas, or maybe just generalized tenderness or pain of those muscles. And then with the trigger points and painful areas, I ask them, does this reproduce that pain that you're having in your penis or in your testicle or in your perineum? And a lot of times they say, you know what, yeah, it does. Importantly, also, we want to make sure we assess the coccyx, because some of these patients actually do have something called coccydynia, which is a non-urologic issue, but can sometimes be related to their pelvic floor issues. So we term this muscle pain myofascial pain of the pelvic floor, and it's essentially pain, or even not necessarily pain, it can be just increased discomfort with palpation of certain muscles. And I don't go through all this effort to try to name and describe the muscles, but I think for our purposes in urology, we want to identify if this is probably a muscle issue, and then refer them to pelvic floor therapy and other specialists that can identify and focus on which muscle groups are affected. So why does this happen? There's all sorts of different things. I mean, I see a lot of different kinds of patients with pelvic floor issues who seem to have it from various issues. There can be repeated micro trauma from vigorous activity and exercise. I see a lot of these guys that do like crazy heavy squats and are not doing any stretching, heavy laborers, construction workers and stuff like that. There's also potential for local inflammation contributing, local trauma, patients who have had sexual assault or procedures. Sometimes people have like a very traumatic cystoscopy because they were super clenched down and trying to constrict their urethral sphincter, and then just insertion of the scope was traumatizing for them. There can also be postural or biomechanical abnormalities, including, even just leg discrepancies, one leg slightly longer than the other, SI joint dysfunction, hip rotation. I see a fair number of Uber drivers, just people who sit all day, who seem to develop issues. I saw a lot of patients through COVID who had really changed they went from being very active to being very sedentary and started having issues. There's a potential also for if they have some sort of pelvic organ pathology, that they could actually have reflexive muscle guarding. And then there's this concept of this pain wind-up phenomenon where just, over time, the body's response to pain is that they become more and more sensitive to it over time. But there's other things that can be causing these same symptoms that are outside of the pelvic floor that are also musculoskeletal that I think you also need to keep in mind. Trochanteric bursitis, referred pain from the lumbosacral spine. I mean, we see this all the time. Sometimes it can be very tricky to convince the spine team that their GU symptoms are coming from the spine, but if you get a block at the right level, you might get some relief. SI joint pain, hip pathology. I think we're becoming more and more aware of how some of these issues may cause symptoms, GU symptoms. Stress fractures, visceral referral. So it's really important. I mean, you have to take a comprehensive history. It can't just be about their prostate symptoms, about their urinary symptoms. You really want to ask, do you have any lower back or hip issues? Do you have any bowel or urinary issues? I mean, these are all really critical questions for these patients. So what's a trigger point? Basically, these focal areas of hyperesthesia, hypersensitivity. They're tender, they cause pain when you touch them, and they actually cause functional problems with the muscles. So it prevents the muscles from elongating like they're supposed to. So it actually prevents the muscle from doing what it needs to. And then over time, from that pain, the muscle is unused and it becomes weak. These tend to respond pretty well to pelvic floor physical therapy. However, sometimes they do require pelvic floor trigger point injections if a patient, particularly if a patient doesn't make adequate progress with the physical therapy. There's been some studies published that have reported that this is the most common and overlooked cause of pelvic pain. So what can we do for these patients? Well, pelvic floor physical therapy is the number one most important thing. I encourage you all to find the great pelvic floor physical therapists in your area. I mean, I think at least most major cities have several options. The pelvic floor physical therapist should in general be doing both internal work with a finger in the rectum and also external for the best possible results. Some of the things they may be focusing on: posture, gait, range of motion, pelvic instability, lower extremity strength, mobility, lengthening the muscles. Okay, all these things can be contributors to pain. They're going to do external soft tissue manipulation and also, like I said, the internal work, focusing on trigger point release, stretching these contracted and dysfunctional muscles, lengthening them, and then once the length of the muscles and the function of the muscles is restored, then strengthening. What you don't want, and what's probably the most common mistake that I see, is just going straight to Kegel exercises. You tell these guys about pelvic floor and you tell them how important it is. They go to therapy and they're like, well, I don't really, want to do that. I'm just going to go online and read about what I should do or hear about, watch some videos, and they start doing Kegel exercise, and it just makes things worse. And the way I explain this to my patients is that I say, if you had a Charlie horse on your bicep and you went to the gym and did heavy bicep curls, how's that going to feel? Is that going to make things better? Absolutely not. It's going to do the opposite. It's just going to injure the muscle further, right? So first thing you want to do is stretching, lengthening, allowing that muscle to recover. And then once it's recovered, build up the strength. And that's the exact principle behind pelvic floor therapy. So what's a trigger point injection for a male? Essentially, we insert the finger into the rectum, we identify the trigger point, and then after providing some anesthesia to the skin, and a lot of times we'll do a pudendal nerve block as well, then insert a long needle into that trigger point percutaneously and inject, a variety of substances have been reported. It could be just local anesthetic. Some have reported use of steroids. Some have reported use of Botox. And the way I use these is essentially I send the guy to physical therapy and they typically make some progress, but some of these guys will hit a plateau where they just are not making the progress. In those guys, I really try to rule out the potential for some underlying musculoskeletal issue in the lower back or hips that may be driving the problem. And if there's not really some reversible issue, or if they're not a candidate for spine surgery or something, if they do have an issue, then we consider doing something like this. But there's other treatments out there. I mean, if they're just having kind of an acute flare, you know, in addition to the physical therapy, a lot of them have been taught stretches to do at home. They do ice, heat, local massage. Stress management is super important because anxiety is definitely a major factor here. Some have reported the use of acupuncture, percutaneous tibial nerve stimulation. Oral medications are sometimes used, tricyclic antidepressants, anti-seizure meds, anti-inflammatories. Another thing I use in my practice sometimes is the rectal Valium suppositories, particularly in these guys who hit a plateau with their PT. Botox, the thought is that, you know, these contracted muscles have reduced blood supply, and if you can kind of force them to relax, it, you know, reduces ischemia, reduces pain. And then pelvic floor low intensity shockwave therapy is an option, but unfortunately, you know, as many of these things, it's not covered by insurance, so not many patients necessarily can afford to pay for that out of pocket. So in conclusion, I just really want to emphasize that for these patients, I don't want you to think this is a prostate issue first. I mean, it may be, but I think we should really be thinking pelvic floor first. And if we can kind of safely rule that out, then we should think prostate or, you know, some other cause. Pelvic floor therapy is truly the only treatment that we can offer our patients that has zero negative side effects. So I have a very low threshold to, you know, encourage my patients to do it. And I think it's really important. One of the things that I do, my fellows here probably make fun of me for, is that I try to spin it as a positive thing. So I tell patients, this is great news. You know, this is a pelvic floor issue. The treatment is not surgery. It's not medications. It's physical therapy. There are no negative side effects. And I think if you kind of come at patients with that angle, I think they're going to be much more likely to be engaged in their treatment plan and participate and then have a positive result. So I also want you to think about the kinetic chain, look for the cause of the symptom, either above or below, you know, the GU organs. Don't just totally be fixed on that, and really focus on multidisciplinary collaboration with our physical therapists, with our psychotherapists. I think it really takes a team effort in these complex patients, and you should not have to manage them alone as a urologist. I'll leave you with this book many of you probably know about. I think this is a great book for both men and women with pelvic floor issues, with a lot of great content that we commonly recommend to our patients. So thank you very much. And I think that is it. So we'll open the floor to any questions. So thanks to everybody for the opportunity to talk.
Thank you all for those awesome presentations. I was going to start with a couple questions that came in that are similar. So there's a few questions on if panel members have seen men with hypoactive sexual desire disorder and how they manage them. And also a question on off-label use of medications for hypoactive sexual desire disorder. For men with low libido and normal testosterone.
It's interesting because when you look at low libido, especially with like literature for men, it's all the testosterone, it's all these things. And then you have like HSDD, which is like a DSM category, classification that's marked by this low desire, but marked distress. But several of us have definitely encountered patients that are in high levels of distress, but they're not diagnosed with HSDD. So I think even when you look at some of these publications, it's really interesting. And the marketing around, Addie and, Vyleesi here specifically, it's like HSDD is like their, FDA indication. So I think we probably are even facing some biases in terms of how we're thinking of these medications because Addie, for example, just plays on hormones that men and women both have. It increases dopamine, norepinephrine, decrease serotonin. So theoretically, it can be used in men, but the FDA indication is premenopausal women with HSDD. And then Vyleesi, they don't even know really how it works. They're like, oh, it's something with melanocortins or something, and it like impacts behavior. So there really is no good reason why. And I think I've actually been posing the question. I'm also like, yeah, why don't we use it more? I think from a practical standpoint, Addie is quite expensive, even for women as well. So I think that really also limits its penetrance amongst patients. But there really isn't any physiological reason that this can't be more of an option. So maybe a group study.
Yeah, I agree completely. I think a lot of men that we're seeing with low libido probably have HSDD if you look at kind of the criteria. I've had maybe 5 or so patients that have done Addie who have had normal testosterone. but still complaining of low libido. And I would say it's probably worth maybe 50% of the time in terms of improvement.
Yeah.
The key thing is that the main side effects normally is hypotension, and a lot of guys they'll take it at night, and if they go out drinking, which they're not supposed to be doing, they wake up in the morning and they have the worst hangover symptoms that they've ever had. So definitely kind of counsel them about that. And I think kind of in terms of the mechanism, Addy, for the most part, serotonin agonist, antagonist, we don't really know how exactly it works. For Vyleesi, melanocortin agonist, which is similar to like PT141, which is kind of something that a lot of guys come in and ask about, which a lot of people have looked at even 2 decades ago. But the problem was it was causing a lot of nausea, vomiting, which is kind of the main side effect of Vyleesi. So I don't know if that's really going to have the same play in men that it does in females, at least at this point. And this strictly would be kind of off label.
Yeah.
I have a question is what you guys have experienced as far as cost. I know that there's various prescription discount programs where it's a little bit more affordable. Do y'all have any recommendations of what to use, what the typical out-of-pocket is?
I personally don't. I have to say I've never prescribed Addy personally. So I just know just kind of based on other colleagues or, just in general, it's quite expensive and most insurance companies, unfortunately, don't cover it, which is an anomaly because a lot of male, sexual dysfunction meds, as we know, is really not covered by insurance companies. Most women's medications, just because from a lobbying standpoint, they've done a better job of being able to get covered, but sexual dysfunction in women is also not well, covered by insurance companies. So,
yeah, I've tried, but I haven't been able to get anybody to actually get it because of the cost barrier.
Yeah, I think it's around about like a 30-day supply is $300 to $500 out of pocket.
Heard something about like Phil RX, like PHIL RX, but I haven't had any personal experience about it. So
that's like a tank of gas in California, isn't it?
Yeah. It's like driving to the appointment, just pick up your Addy on the way home.
That's funny.
Okay, so next question. Any specific ongoing monitoring parameters for cabergoline over time?
Yeah, it's a great question. So, I mean, generally, in terms of kind of side effects and counseling, the most common things, dizziness, headache, nausea, vomiting, weakness. It does have somewhat of a hypotensive effect, so it can lower blood pressure in some patients. Long term, the data that we have is based on patients that have been on it for other hyperprolactinemias, and they've been on higher doses. So generally, I think the recommendation for the valvular changes or valvular abnormalities and monitoring for that will be on men that are on more than 2 milligrams a week. And generally for this indication, we're using half of that. So I haven't had any patients that I've monitored specifically for valvular abnormalities, just based on the literature for hyperprolactinemia and other indications for cabergoline or other dopamine agonists.
Okay, next question. How effective is pharmacotherapy in delayed orgasm?
Yeah, I mean, generally, I would say if they have low testosterone or low normal testosterone, those guys with testosterone therapy tend to do fairly well. In terms of the other therapies that we kind of discussed, I would say the success rate overall is probably about 30% in terms of all comers. The one thing I like about cabergoline is that generally it's 30% for everybody. I know that for other pharmacotherapy, some people that have orgasmic dysfunction after prostatectomy tend to do better with certain, and like Dr. Bayach mentioned, the Adderall tends to work better with a specific phenotype of patients that are kind of coming in. I don't know what other guys' thoughts are.
I don't have a thought as much as a question, but what do you guys think is the % success rate in your experience of sex therapy in these patients?
The ones that go.
The ones that go, yeah.
I've had actually a really positive response from my patients that go to sex therapy. I mean, I think that's also something that could just be either cost prohibitive or, if you have a good fit with your therapist. But I agree, it's like it won't like pelvic floor physical therapy, right? It's just like I don't think it's going to hurt anyone, it may not help, but I think certainly if you really want to load the boat and, maximize your options. I talk to sex therapy. I talk about sex therapy to all my patients. I'm like, that would only make your life better. So I'm a huge advocate for it.
Yeah, I agree. I mean, it's hard with access. I mean, our wait list for sex therapy and physical therapy is like 4 months, which is ridiculous. But a lot of patients that are coming in, they have considerable anxiety about their condition, and I probably would say that probably 50% or more are going to benefit from sex therapy if they end up going. Comparing that to pharmacotherapy, obviously they're getting a lot more bang for their buck.
Yeah, I couldn't agree more. I mean, I think that if we can convince them to do it, and if they have the resources to be able to afford it, I mean, way higher success rate than pharmacotherapy, and really we should be spinning it as first line, I think, for a lot of these guys. A lot of them, they try the meds and then they end up finally agreeing to go to therapy, and then they're like, oh, this issue was the problem and now we're good. It's like, okay,
Right.
we could have skipped a lot of steps there, but
Right.
With the access cost issues, I've been trying to get some patients to go to like Talkspace and some of those online therapy places that have sex therapists, but nobody ever goes. So I haven't really had anyone report back, but I do know that they do have sex therapists. So I'd be interested to know.
I think there's probably, go ahead, sorry, Denise.
Oh, no, I was just thinking of like a database, even with SMSNA. I don't know offhand if we have, sex therapist database, if there are, members who are part of SMSNA, similar to how urologists are on like a database. That could be a good resource to refer patients to.
Yeah,
Great.
similar to what I was going to say is it would be great if SMSNA had some sort of library of reliable, even video content that's free, because I think a lot of the concepts are, probably common amongst these patients, that they could at least have a reliable place to go for content that they can utilize if they can't afford to actually go to individual therapy.
Yeah.
We'll have to discuss that later and forward that on. Okay, so next question is specifically for Dr. Patel. On your table for delayed orgasm medications, do you have like a publication or citation that this person could refer back to?
That table was kind of derived from a publication from Lawrence Jenkins, I think in 2014 or 2015. He had a good paper with Dr. Mulhall. I think it was infertility and sterility, which is like my go-to, and I still use it as a good reference. So I think I definitely recommend checking that out.
And then last question for now is, can COVID-19 affect libido, arousal, or orgasm? So I'd like to hear everyone's comments on that.
Dr. Ramasamy would love to hear this. No, I mean, I think largely, we have found that COVID is not the culprit for everything that's happening. And I think of more kind of secondary effects. So you got COVID and now you're dealing with chronic fatigue and a brain fog from COVID. That's really the culprit. But I think linking it directly to low libido is a bit of a stretch. I think those of us in the sexual dysfunction world have seen a lot of things that have been attributed to COVID, but I would have to say there has been no evidence showing that it directly causes low libido. So I don't know what you guys have found or if I'm up to date with my literature search.
I would agree on the literature aspect. What I would say is that having COVID, or even some patients having a COVID vaccine, and they can sometimes get in their head about what they think is happening as a result of it. It is not necessarily based on any sort of physiology, but like a severe anxiety about some possible effect it's had on them, as to whether or not you consider that as a cause of COVID or not. But I think the severe anxiety, which gets back to the benefit of sex therapy and the benefit of talking through these kinds of issues that we're talking about at this webinar today, I think there's always a component. I mean, I think that these guys can totally psych themselves out and convince themselves that they're just broken. and it becomes a self-fulfilling prophecy. So I think we have probably more power than we think in, listening to them and kind of digesting that and giving it back to them in a way that's like, okay, this is why you feel this way. It's not actually because the COVID thing broke you, vaccine or virus, but like you can get back to how you were. These are the steps that you need to take to do so. So I guess in other words, I don't think it really causes a libido issue, unless I probably had like one or two guys who, for it's unclear why, but they all of a sudden have low T associated with these symptoms and respond to TRT. But for the vast majority of guys that came in convinced that COVID broke them, I mean, there wasn't really any physiological explanation for it.
Yeah, I mean, I would agree. I think that a lot of patients that are dealing with these conditions, obviously their first step is go to the internet, and that's kind of a dark place because there's a lot of media, articles that are very sensationalized, things like low libido, erectile dysfunction, that kind of stuff. And, that same thing, it kind of gets in their head. And at the same time, COVID certainly had a huge impact, not only on kind of these conditions, but, life overall. So a lot of psychosocial stressors that guys are dealing with that can also kind of affect sexual function. So just based on literature, I don't think there's a direct relationship. There certainly is an indirect relationship, just given kind of the magnitude of the pandemic.
Yeah.
Okay, thanks everybody for coming. Thank you so much, all of our panelists, for those awesome presentations. I know I learned a lot, and I hope everyone else did as well. Yeah, thanks for having us.
Awesome. Thank you.
Ask everyone to just smile real quick for
Thanks, guys.
Okay. And good.
Oh, screen share.
I'll send it, don't you worry. All right, thanks everyone. Have
All
a
right.
good night.
Thank you. Bye-bye.
Bye.
Thanks.
Thanks, guys.